And welcome to the really very first face-to-face Big Data Neurosciences Center seminar since 2019, the end of 2019. We're really honored to have Dr. Shi-Yi Wang join us today. Very bravery to come here during the surge of the new epidemic. But we're glad that we have this kind of gathering event. Dr. Shi-Yi Wang really is a very good friend and my mentor as in my postdoc training. And he's really an expert in a lot of research focusing on oncology science. His primary research is on outcome research and decision science. You can see in the bio of the flyer, he's an associate professor from the Yale School of Public Health, Department of Chronic Diseases Epidemiology. Our first project is really on the Medicare data and linked to SEER cancer registry data to really identify a very important controversy cancer treatment, which is sentinel lymph node biopsy. So this is a procedure that was very controversial, and he co-funded research helped me to fund my postdoc training and really identify short-term and long-term side effects, cancer recurrence, and survival for breast cancer patients with without sentinel lymph node biopsy. Of course, there are more with that. Dr. Wang also got funding from a lot of different local and national agencies like AHRQ is one, NCI, Yale Cancer Center, and a lot. And recently, he is proposing some kind of simulation model to really wanted to improve the really bridge big data in oncology science. It was recently funded as a U01 from NIH. And there's so much to talk about Dr. Wang's research. And I don't want to take all 55 minutes of this session. So let's welcome Dr. Wang to introduce and share with us his innovative and newly proposed simulation model focusing on the oncology. Let's see.
Thank you, Pei, for the invitation and the introduction. I'm glad and honored to have this opportunity to share my research project in University of South Carolina. And I enjoy working with Pei before, and I hope this presentation can keep our network and our collaboration in the future. So, data is a crucial component in research. Researchers have analyzed observational data to advance our knowledge. For example, our group use different data sets to examine health expenditures, mortality and morbidity, and health-related quality of life. Simulation modeling is a powerful tool, and by integrating simulation modeling and big data science, we can understand more important critical issues, such as overdiagnosis, and we can conduct cost-effectiveness analysis to help policy decision makers regarding resource allocation or value-based practice. We can further conduct value of information analysis to understand research priority. In today's presentation, I would like to first share two examples in which we use a big data simulation approach to examining breast cancer overdiagnosis. I will then discuss our new project in natural history modeling for multiple myeloma. And feel free to interrupt me if you have any questions during my presentation. So since I am going to discuss big data in oncology, so of course I should have a talk about data sets in oncology. I know South Carolina has a very rich data set linking tumor registries with clinical data. Unfortunately, it is a little bit limited because of generalizability, as well as may have an issue about small sample size. So here, I just provide some examples of national data. The most famous one is SEER, or Surveillance Epidemiology and End Results. SEER-Medicare, there have been about 5,000 publications using SEER-Medicare data. And I'm not sure whether you are aware about SEER-CAPS data. CAPS stands for Consumer Assessment of Healthcare Providers and the Systems. It provides surveys about patient-reported outcomes. But each data set has its weaknesses and strengths. For example, in oncology research, tumor characteristics such as grade, such as stage, tumor size, is a very important prognostic factor. But if we only use claim database without tumor registry data, we will miss this important information. However, SEER also has some limitation. For example, SEER only does not have treatment information. And the SEER-Medicare is limited to patients who are older than 65. And of course, we can use algorithm to identify side effects or hospitalization, etc. But right now, the movement toward patient-reported outcomes or patient-centeredness, I want to highlight two data sets which contain patient-reported outcomes. The first one is SEER-CAPS, another one is MAPS. Okay. And of course, when you want to do the research using this data set, you need to be aware the weakness and the strength of each data, of the data you use. So I want to talk about the two projects. Both of them are related to overdiagnosis. So Dr. Rage provide a very good figure to present overdiagnosis. Overdiagnosis occurs when screen detected cancers are either non-growing or so slow growing that they never would cause medical problems. So we can see that screening can detect cancer, but only beneficial for the slow cancer, which can lead to death. However, the very slow cancer or non-progressive cancer would lead to overdiagnosis, which would not have any impact on patient survival. And this is a critical issue in screening. And I will show this later on. So the first project is related to pre-operative breast MRI and contralateral breast cancer occurrence. The use of pre-operative breast MRI has increased dramatically in the United States, and it's controversial. The proponents argue that breast MRI can improve cancer detection in evaluating tumor extent and multicentricity in the ipsilateral breast, and also can screen contralateral breast cancer, or CBC. A randomized control trial conducted in the UK, which enrolled about 1,600 patients, showed that MI did not reduce reoperation rate. Okay. And it does not have a power to test whether or not breast MI can reduce contralateral breast cancer. So we conduct an observational study using SEER-Medicare database. And SEER represents approximately 30% of the US population and provide information on tumor characteristics. Medicare claim data include comprehensive utilization information in outpatient, inpatient, hospice, etc. So we identified about 36,000 fee-for-service Medicare female beneficiaries with stage 1 and breast cancer. And we use CPT codes to identify pre-operative breast MRI use. The uniqueness of this project is to use SEER sequence number to identify CTC occurrences after primary breast cancer diagnosis. This is an important issue. When we use SEER or tumor registry data, they collect the tumor characteristics when cancer is diagnosed. But we do not have information about tumor recurrence. Generally, we use algorithm to identify a proxy representing local recurrence. Okay, but the good thing for the SEER is that we can identify the CBC occurrence because SEER treats it as another cancer. Okay, and we use cutoff point of 6 months to separate synchronous versus subsequent or metachronous CBC. We use propensity score matching to control confounders, about 6,000 patients and 12,000 controls, 1 to 2 matching. We also use Markov models to project number of synchronous and subsequent CBCs during a 5-year follow-up by receipt of MRI. So I will not go to the details about the matching process, but basically both groups with or without MRI are compatible. And we can find that compared to patients who did not receive MRI, the MRI group has higher CBC incidence rate, a synchronous CBC incidence rate, including in situ stage 1 and stage 2 to 4 advanced breast cancer. This is not surprising because this is the purpose of the strength of pre-operative breast MRI. And we also find that subsequent CBC incidence rate is higher, in situ CBC incidence rate is higher in MRI group compared to no MRI group. And stage 1 is reversed. So MRI group has low stage 1 CBC incidence rate compared to those who did not receive MRI. So this shows a stage switch. Okay. However, when we compare cumulative CBC occurrence incidence, we can see after 5 years of follow-up, the group patients who underwent MRI have a much higher in situ and the invasive CBC cumulative incidence compared to the no MRI group. Even if we look at the invasive CBC occurrence incidence, we still can find that at the 5 years of follow-up, the MRI group has higher cumulative incidence compared to the no MRI group. So we use Markov model to simulate the number of CBC among 10,000 women. And we find that there are more synchronous in situ stage 1 at the advanced breast cancer. And we saw a decrease in subsequent stage 1 and advanced cancer in the MRI group. But overall, pre-operative breast MRI leads to increase the number of a patient with in situ and the stage 1 breast cancer, and that does not have any impact on advanced breast cancer incidence. So we acknowledge the limitations. For example, this is an observational study, and we only use propensity score to control potential confounding factors, and we cannot control unobserved confounding factors. And the population is limited to older population. But we can conclude that breast MRI use was associated with a shift in stage at the diagnosis for subsequent CBC events. So basically, an increase in subsequent in situ CBC occurrence, but a decrease in subsequent invasive CBC occurrence. However, the decrease in subsequent CBC events did not counteract a large net increase in synchronous CBC detection. So there is no evidence of a reduced overall advanced CBC events. So we can see that, in fact, breast MRI would lead to overdiagnosis. Okay. Any questions? Okay. Now I move to the second point. Okay. Yeah.
Are you going to the next project?
Yeah.
Does timing of MRI use matter in terms of the occurrence? So when did they use MRI during this time? Does that matter or?
So it depends. Of course, we didn't check whether or not a patient who received pre-operative breast MRI after patient receiving surgery. So we can imagine that for patients who received or underwent breast MRI, pre-operative breast MRI, would be more likely to receive additional screening, such as breast MRI screening for contralateral breast cancer. That's possible. But overall, we can see that the MRI use actually is associated with an increase in overdiagnosis. I understand your question. If you are asking whether or not this group also receive additional diagnosis right? Yeah, it's possible. But we can think it's related to the breast MRI. But more importantly, it's that the increase in the beginning of the contralateral breast cancer occurrence in the synchronous in the first 6 months actually is related to pre-operative breast MRI use. although there would be a minor increase in terms of additional testing for the MI group, but you can imagine that this is almost flat. So even if you think that it's similar here, the no MI group does not have a high incidence rate compared to the no. This is still smaller. Does this make sense? I think I answered your question.
There is a question in the chat box.
Yes.
So if you click where there's a notification there. Here. There is a question from Suda. It says, is there a bias in who receives an MRI which may predispose these patients to be observed outcome?
Yeah, this is a good question. So the question is there a bias in who receives an MRI which may predispose this patient to the observed outcomes? This is a good question. And actually I answered in the paper that the diagnosis of a contralateral breast cancer is recorded by SEER, the tumor registry. It is unlikely that the tumor registry would index CBC according to patients who receive MRI or not, because they are tumor registry personnel. So I think it's unlikely to have a bias due to this issue. I hope I answered your question. Okay.
Have you tried to move the 6 month back and forth to see if results change? The 6 months sounds like a subjective.
Yeah, but I think it would not change.
Or just because of the lag?
Yeah, because it's quite similar.
There's two more questions.
Okay,
Sorry.
that's fine.
One is a follow-up from Suda and the other is from Dr. Goodman.
Okay. So everyone in this cohort has insurance, has Medicare insurance. Of course, insurance assets would be biggest issue when carry structural bias. We control their insurance status using SEER-Medicare. So basically, they have a Medicare plan, and I believe we also control for their private insurance. But MI decision is made by the clinician, not the registry. Yeah, so it's made by clinician, not the registry. But the registry would not make the diagnosis of CBC. So I think you may be asking, maybe clinicians were more likely to make diagnosis of CBC. But I don't believe that clinician would, when they found the CBC, they would not say, no, you don't have CBC, right? I still think that should not be a problem.
So is it possible physicians are aware of the MRI and they are more likely to be cautious about CBC?
Yes, but this is related to the use of CBC, of MRI.
Right.
So this is related to MRI use.
Right.
Okay, now I move to the second project. Are small breast cancer good because they are small, or small because they are good? So, because of screening mammography, overdiagnosis has become an issue. So we can see that after screening, the incidence of localized breast cancer increase, and there is a modest decrease in terms of metastatic or regional breast cancer, suggesting the benefit of screening mammography. So I have no doubt about the benefit of screening mammography. But there is a concern of overdiagnosis. And Dr. Wich published a paper in New England Journal of Medicine. They found that since adoption of a screening mammography, small breast cancers have increased in incidence over 3 times more than large cancers have decreased. So many small cancers are not destined to progress to large cancers. Instead, their detection can result in overdiagnosis. So the goals of our project are to characterize groups of tumors that are likely to contain a large proportion of overdiagnosed cancers, and to explain the mechanism that may have led to their overdiagnosis. So we use SEER data, not SEER-Medicare. So basically, this project does not involve in treatment. And then we also analyze National Cancer Database as a sensitivity analysis, but the results are quite similar. So I would just focus on SEER data analysis. So invasive breast cancers were divided into 3 prognostic groups based on biologic factors. Grade 1, 2, 3, ER status, positive or negative, and the PR status, positive or negative. So basically, there are 12 groups. We categorize them into 3 groups. The first one is biologically favorable group. So it's grade 1 with ER positive or PR positive. Biologically unfavorable include grade 2 ER negative and PR negative, and the grade 3 either ER negative or PR negative. And others, all other groups are in the intermediate group. So we determine the distribution of these 3 groups across tumor sites. We examine the associations of the tumor size and the biological features with breast cancer specific survival. We evaluated the mean lead time across the 3 prognostic groups. So the lead time is the length of time between when a cancer can be detected by screening and when it would have become clinical apparent without screening. Prior literature suggests that it's around 40 months. Okay. And then we simulate life expectancy and the lead times and calculate the percent of an overdiagnosis, which means the fraction of women with life expectancy less than the lead time. So among patients younger than 40 years, we can see that there is a substantial difference in terms of proportion of tumor biologic groups across tumor categories. And when we look at patients older than 40, so they are more likely to receive mammography. We can see favorable tumor characteristics groups with favorable biologically favorable group increase to about 40% in the small tumor category, and it reduced to about 9% for tumor larger than 5 centimeters. And the unfavorable group increased from about 14% in small tumor category to around 37% in the large tumor larger than 5 centimeters. So this slide actually provides important implication. If all tumors progress, even at a different rates, you can expect a steady state to be reached across tumor categories. Okay. So large tumors do not arise equally from small tumors. Rather, they develop preferentially from a distinct subgroup of tumors with unfavorable biologic characteristics. So this provides quite direct evidence that not all tumors would progress during the patient lifetime. And then we compare the breast cancer specific survival. We can see that for patients with larger tumor, T2, favorable tumor characteristics actually have a higher, better survival than small tumor, but unfavorable tumor characteristics. And also the difference for the impact of a tumor size is smaller among patients with favorable tumor characteristics compared to unfavorable tumor characteristics. So we estimate mean lead time among 3 tumor biologic groups using different such as Weber and exponential distribution, assuming lead time has Weber or exponential distributions. And we can find that for unfavorable biologically unfavorable group, the lead time can be small, can be very short, as 2 years. But for the favorable group, the lead time can be very long, more than 20 years. And if we think about patients' age, patients who are older, of course, they have a shorter life expectancy, and they will be more likely to be overdiagnosed. Especially if you think about their biological characteristic, then for patients with older than 80 and have a favorable tumor characteristics, the overdiagnosis percentage can be higher, as high as 70%. So to some extent, I would say tumor size is a proxy of a tumor, good or bad tumor tumor. So small breast cancers are small because they are good. Okay? And the key issue is that I think overdiagnosis is inevitable. So basically, because we have a screening mammography, but we should avoid over treatment. So educating physicians, patients, and the public that some tumors are indolent is important, so that not all cancers need to be treated. Okay. So any questions? I think I will move to the next one. Okay. So now no question, right? So I will go to discuss our new project in natural history modeling for multiple myeloma. So basically, there is a U01 funding opportunity announcement for a new incubator group. So this FOA aims to accelerate the development and the application of cisne type models for new cancer sites. So of course, I need to explain what is cisne. So cisne stands for Cancer Intervention and Surveillance Modeling Network. It's a consortium of NCI-sponsored investigators who use simulation modeling to improve our understanding of cancer control interventions in prevention, screening, and the treatment, and their effects on population trends in incidence and mortality. And the existing six cancer sites include breast, cervical, colorectal, esophageal, lung, and prostate cancers. So they are very influential. They are a very influential group. Actually, they publish a lot of papers about the screening for breast cancer, lung cancer, or colorectal cancer. And actually, they also provide evidence for U.S. Preventive Services Task Force to make treatment recommendations. Okay. So I would describe some of the multiple myeloma because it's different from breast cancer. In 2020, multiple myeloma was estimated to account for around 13,000 deaths, and the median survival after diagnosis is only 43 to 83 months. And the treatment for multiple myeloma is very costly. For the first year, it's about $140,000 in the first year after multiple myeloma. And in general, multiple myeloma is consistently preceded by a pre-malignant condition, monoclonal gamma positive of undetermined significance, or MGUS. Okay. But right now, there is no screening or treatment for MGUS. But the cost burden is substantial. So I work with researchers from Washington University at St. Louis, and we respond to this FOA, and fortunately, we got funding. Okay. So the specific aims are to comparatively build, calibrate, and validate evidence-based multiple myeloma modeling across the MM continuum, care continuum. And we will assess the impact of a novel intervention strategy on MM prevention in high-risk patient diagnosed with MGUS, and evaluate the impact of novel treatment regimens on survival outcomes among patients diagnosed with multiple myeloma. Finally, we will assess whether under what condition and in which ways the goal of eliminating racial disparities can be achieved through the proposed novel intervention strategies and the treatment regimens. Okay. So basically, we have a conceptual framework, and we need to think about the population from the age, sex, and the race. And obesity is well-known factor for multiple myeloma development. And of course, after patient with MGUS progress to smoldering myeloma to multiple myeloma, treatment will influence survival, and the patient's comorbidity will influence treatment strategies as well as survival. So basically, we will create simulation model to model a population, first cohort. Everyone went to the model, and they will encounter sequential events, etc. The Washington University researcher will use discrete event modeling, and our group will use a different approach. We will use individual-based, stage-dependent, and state microsimulation to simulate natural history. So we will have a patient with different sex, age, race, and obesity, and whether or not they developed MGUS, and whether MGUS was diagnosed, so that screening strategy will have an impact on survival or outcome. And smoldering myeloma, whether they will be diagnosed, and then to multiple myeloma, and the treatments, and to death. So we need to collect data in terms of demographics, risk factors. We need to think screening diffusion and the diffusion of treatments. And both of our groups will use data to model the population multiple myeloma incidence and death, and using longitudinal data. So to do that, it's a little bit tedious, but we need to use data from multiple sources. For example, we need to use enhanced maps and to calculate the incidence of MGUS. And we need to look at SEER-Medicare or glucose shield to see treatment patterns. Okay, then we can combine them together. And also, researchers from Washington University will focus on the MGUS, the probability of MGUS to multiple myeloma, etc. And we combine all of them. We can create models, two different models, and we will calibrate our model because simulation is not real. So we need to calibrate as well as validate our model. And in case that the results are not similar, we need to revise our model, and we potentially need to use Flatiron or multi-scan different data set to see how we can improve the accuracy of our models. This is an example. So basically, some preliminary data. So we use enhanced data, so we can calculate the MGUS instance by different age, BMI, and race. So basically, this is just you can think about for individual microsimulation or discrete event simulation. Actually, they will consider all of these demographics and the risk factors. And this is the prevalence of or incidence of multiple myeloma. So basically, we need to build a model and calibrate our output so that the prevalence incidence are similar. So this is the model that the researchers from Washington University proposed. So basically, they want to use discrete event model. So basically, we need to get the parameters by data analysis and then combine them together and build a natural history model. And for our group, we will do treatment patterns first and then get literature about treatment effect. And then we collaborate each other. Our data, we will provide data to Washington University. Washington University will provide their early stage or preclinical stage, the parameters pre-cancer stage. So we will share parameters, but our calculation methods are different. Our simulation models are different. So basically, both of our groups will compare our results together and see how interventions can change the result, can improve the results. For example, researchers in Washington University are specifically interested in metformin for multiple myeloma prevention. So they propose to do cost-effectiveness analysis of screening plus metformin treatment. So they tend to do cost-effectiveness analysis on this issue, and we also want to do value of information analysis to identify future research priorities. And for me, as a clinician, I'm more interested in treatment effectiveness. So this is also the reason why I take the data part of this modeling. So I would evaluate novel treatments for the cost effectiveness analysis for novel treatments. So thank you for your attention, and I'm open to any questions you may have to my presentation.
I will keep an eye on the chat box.
Okay.
Might take a minute.
My questions can be very long. Two teams proposed a variety of different databases in order to predict the preventive efforts and treatment efforts in ready. We need to get a very good model to predict the survival of all other outcomes. But then for all those CBC data, there may be multiple, like one individual can be sampled multiple times across all those data sets. How are they going to address this when all those data sets have one person counted multiple times?
I know what you mean. So basically, you are afraid that we may violate the independent observation assumption. But for each analysis, actually, we just only use one data set. So basically, we use one data set to get a point estimate, 95% confidence, for example, percentage, 95%, right? Or treatment effect, 95%, 95% confidence interval. So basically, we use this. And then when we have another one, we will change the parameter. And then depending on the simulation model, for each time, actually, we do not count it twice. So basically, we just use the input parameter to the data set. And then we want to see which, actually, we hope the first parameters are accurate, and we can build a validate model that is accurate, right? But in case that's wrong, inaccurate, then we can modify it like a backup plan. We can modify our parameters and using our data set, and to see how different. And then potentially we can identify the reason why these parameters are different, right?
By including different covariates from different data sets, your confidence intervals are going to vary.
Yeah, but for each simulation, actually, we will use one set of the parameters first. We will not use both parameters at the same time, or even do pool analysis for the exact. No, this is not our intention.
There is a question, two questions, one from Dr. Adams, and she's asking if you have information from the earlier slides in any of your publications. so that she can reference them in her upcoming submission. Tutorial of the state of cancer and treatment data. I'm not sure which slide that is.
I'm not sure.
This presentation will be available afterwards. We're recording it, so maybe Dr. Adams can find the specific slide she's talking about, and she can email you to ask more.
Yeah, sure. I'm happy to answer any question, and hopefully we can have a collaboration project in the future. Yeah.
So can you speak more to how you use propensity score for matching, and on what variables were you matching based off of?
I didn't discuss the details about the propensity score matching, but in general, in our SEER-Medicare data analysis, actually we will control for patient demographics such as race, ethnicity, age, right? Variety, and sometimes Medicaid as an indicator for poor income status. And also we will include the ecological variable such as region, education, and also income status, but they are ecological variables. We will also control for pre-operation Medicare healthcare utilization patterns. We will also control for tumor characteristics such as tumor size, stage, etc. So basically, they are included in the propensity score matrix. Of course, we will make sure that they are well balanced. Do I answer your questions?
So
Actually, it's quite standard.
I think I want to follow up on Becky's question. So you basically like conceptually or pick up those variables for matching, or you have a criteria like selection criteria what variable you're going to including for matching? Because, for example, different groups looking at your data sets, they come up with different variables for propensity score matching. So is that convention? I mean, what's the conventional way to decide?
Yeah, this is a good question. I mean, in general, we did not develop new variables. We just follow previous research, how the researchers conducted before. In general, these variables are available and only available. I mean, I would say we are limited to use the available variables in our propensity formation. So this is the reason why I mentioned that I am unable to control and observe confounded factors. So we did not use IB analysis because the confidence interval issue, etc. But generally, we use variables that previous literature used. But this is also an interesting question because any data she is a researcher from Maryland and went to Yale before, and right now she went to NCI. She developed a distributivity score, so basically you can use this variable. I believe we also use that one in our propensity formation. So basically can capture to some extent the patient's status, comorbidity status, not just only claim-based comorbidity index. Okay. And right now, our group is applying for another score, frailty score. If you have questions, I can email the new variable, which is developed by someone from Harvard, so that use the frailty score to indicate patients' frailty, because it's very important in the older population. Yeah. So.
Sorry,
keep this question following. So after you do the propensity score matching, when you do the simulation or prediction, are you still going to adjust some other variable except those matched variables?
No.
No, so only like say what's the exposure and the alcohol.
Yeah.
Okay, good. Thank you.
Go ahead.
In terms of volume, what numbers are you talking about per year? Or are you looking at this just cross-sectionally in terms of the number of patients that are in those databases with those cancers?
So basically, this is also I mentioned that the data from South Carolina has some kind of limitation because you can only focus on popular cancers, the top four cancers. But for other cancers, South Carolina may not have sufficient sample size. For my study, for example, for the pre-operative breast MRI one, the breast cancer, I mean, as I mentioned, we identify about 36,000 patients with breast cancer stage 1 to 2. And in our propensity score matching, we identify about 6,300, I forgot, more than 6,000 patients who underwent breast MRI, and 1 to 12,000 patients without MRI, and we do mention. So the sample size is quite large, so that we can do analysis.
I think his question is that the MRI treatment is determined concessionally the baseline.
Yeah.
You're not really tracking.
Yeah, we do not to check whether or not they receive additional MRI, but of course we can imagine. Of course, they would be more likely to receive additional MRI follow-up. But as I said, the number does not increase much, so I don't think it would be a serious concern.
I think this is going to be the last question. It's from Dr. Goodman, and because we can't see it very well, I will read it. It says, why did you select multiple myeloma for study of the natural history? I love natural history information, but is there a compelling signal that we need to treat earlier or identify early MGUS to multiple myeloma transition?
Okay, this is a good question. So basically, there have been 6 cancer types, 6 names, groups, right? So I cannot do model for these 6 important cancers. And the reason why we do this one is because the researchers in Washington St. Louis, they applied for our want to do randomized control trial about metformin treatment for MGUS. And they were rejected because they do not, the reviewer mentioned that you don't have model. So then, when this FOA was out, the researcher from Washington St. Louis, Washington University St. Louis, immediately contacted me and said, hey, let's do model. So that's the reason. Sometimes projects are going in this way that you cannot predict how and why to happen. But something you prepare and then suddenly you do it, and unfortunately you get time. Then you do the project.
Yeah, so a quick follow-up. So if your model succeed, can you talk a little bit more about how would that advance the prevention and the treatment of multiple myeloma?
Yes, so basically that's our hope. And actually we also want to decompose the reason why there is racial disparity in multiple myeloma survival. Basically, we can simulate using different parameters, assuming African Americans have a similar obesity pattern as white population, something like that. So basically, we can do, as long as we can build a natural history model, we can do a lot of things. That's what I say.
Thank you for your presentation. From the physician's perspective, the SEER data included patients over 65 years of age. So we should be careful. You said that it leads to overdiagnosis, and we should be careful when starting treatment. What about because breast cancer can also occur under 65 years of age? The patients under 40 years of age, or like demonstration rate. Is there any study, any data that include patients under 40 years of age, 65 years of age? Is any other studies conducted for the patients of that age group? What is your suggestion?
Yeah, I mean, we always want to have a data set which include all population treatments or patient reported outcomes, but unfortunately, it's unavailable in the United States. So in our project, actually, we will use different data sets such as glucose to share for patients who are younger than 65. And then another data set, red iron, actually is very useful. It also includes patients who are younger than 65 and that has cancer characteristics. And actually, red iron also has genomic testing report, so it's very good. Unfortunately, that data set only has physician provider files. They did not have a hospitalization, etc. So basically, each data set is incomplete and has its weakness. So when we want to do the analysis using these data sets, you need to be aware of what is the weakness